Now we shall move ahead to our next academic session. For this, I welcome Dr. Nitin Kapoor, who is the professor and head of Unit 1 Department of Endocrinology, Diabetes and Metabolism, CMC Vellore. So sir is a very well-renowned personality in the field of endocrinology. He has been conferred multiple awards and has numerous publications to his name. So today he'll be talking to us on the topic of obesity and its relationship with kidney disease. So words are not enough for me to describe all his achievements. So I hand over to sir to discuss his presentation.
Thank you so much for that very kind introduction. Thank you, Dr. Binoy and Team Nephrology for having me here. I apologize for my bad throat, but still we'll try and take you through this topic in the next 15 minutes or so. So the topic given to me is from weight gain to kidney strain. Can I have my slides, please? And the obesity-kidney link. And I thought a simple way to assess or address this topic is just by answering three simple questions. I will answer three questions, that is the what, the how, and why. We'll see what is the problem statement of obesity when we look at from the lens of CKD, not only globally, but India, not only India, local data from Vellore, and especially when we look at this from the lens of CKD. We'll see how obesity and or fat and the kidney is linked, what we may call as the adipocyte-nephron crosstalk. We'll see how are the mechanisms that is now called as a nephrotoxic triad in terms of altered hemodynamics, the metabolic changes that happen, and the adipose tissue per se in the kidney. How does it really cause all the damage? And last but not the least, why is it important for us as clinicians to understand this link, and what are the clinical implications of this weight gain to kidney strain topic? So these are three questions I'll answer. Let's get started with the first question. I think all of us would agree that obesity is becoming a big problem globally, as well as in India. When you look at data from India, this is data from the National Family Health Survey 4. We found that about 35 to 40% of the Indian population is either overweight or obese. This has really increased as compared to NFHS 3, especially talking in terms of the state of Tamil Nadu, where we right now are. We've seen that there's a remarkable increase, especially in men. Earlier on, obesity was thought to be predominantly a problem of women, but we see 75% increase in the prevalence of obesity in men, and this was NFHS 4. In 5 years down the line, we had NFHS 5 data, and whatever was in late 30s has now become early 40s. So the prevalence is increasing very, very rapidly. When you look at data from the city of Vellore, and this is a school study we did a couple of years ago, almost published 10 years back, where we took 4 schools in Vellore, 2 private, 2 government, around 300 children between the age of 12 to 16. We find that 1 in 3 school children in a city like Vellore, which is not a first-tier city, not even a second-tier city, at best a third-tier city, and still 1/3 of school children in Vellore have obesity. And even in the young adults, looking at our own data from the Vellore birth cohort, rapid increase in middle age as well, even in the elderly, and this is another community-based study where we looked at elderly women, mean age of 61, again, a big chunk have overweight and obesity. But when we look at this prevalence of obesity from a lens of CKD, and we look at how with each grade of obesity that increases, the prevalence of CKD increases, we see that it is gradually increasing. For a minute, we may think, yes, obviously people with obesity are more prone for diabetes, more prone for hypertension. Obviously, diabetic kidney disease, hypertension-related kidney disease would be more common. But if we deep dive into literature, we try and understand with the help of different logistic regression, the different cohorts that we look at. This particular study looking at around 2,000 individuals, follow-up of 15 years. And after multivariable logistic regression analysis, looking at just the impact of obesity on increased microalbuminuria, we see an odds of 1.9. There's another large collection of different cohorts, a large meta-analysis, 39 cohorts, data for over 600,000 people. Again, looking at the relative risk of developing low GFR and albuminuria, especially just associated with obesity, it's high. And even data from the US Renal Data Registry, which is around 1,400 people, we see that the odds increases. And again, this is an adjusted relative risk that you're looking at. The odds increases as the severity of obesity increases. And if we look at morbid obesity, the last one, which is in orange, BMI more than 40, the odds of developing end-stage renal disease is 7. So that is 7 times higher. So definitely there is something just beyond the comorbidities that are associated with obesity, leading on to CKD. There could be a direct link. There is a link not only in terms of BMI, but I think this is something which is more relevant to our population, where waist circumference is more important. There is an equal kind of a graph as we concentrate on the right-hand side and see as the waist circumference increases, the BMI increases, there is an increase in the odds of developing CKD. This is very relevant in our scenario because our body proportions are not really those of very high BMI, but we do have a lot of fat. And we have this phenotype that we call as the normal weight obesity, where people may have normal amount of BMI, but still have high body fat. This is a study that we did in a cohort in Kerala. We found that 1/3 of the population in this study from the general population, so 1/3 of our population has this phenotype called normal weight obesity, where they may have normal BMI, high body fat, and these people have fairly large prevalences of diabetes, hypertension, dyslipidemia, at par with those who have obesity. And so definitely the way we are looking at and measuring obesity is also changing. So long story short, the first question that we're trying to look at, the problem statement of obesity is really big. Obesity is linked to CKD. As the severity of obesity increases, the chance of developing CKD also increases. There is probably a direct link, and it is not only just in relation to BMI, it is also in relation to waist circumference, which is something relevant to our population. So how are they linked? How is just obesity linking up to cause a problem in the kidney? And there are 3 broad pathways which are described. We'll look at it, each one of them. The first pathway that you see here is the adipose tissue pathway, where we know that there is a lot amount of fat, and fat today is considered as the largest endocrine gland of the body. It's no longer just the way we read in physiology many years ago. It's just to insulate and prevent from cold, and it's just dormant tissue. It's no longer considered as a dormant tissue. It is considered as the largest endocrine gland of the body because it does produce a lot of hormones, a lot of adipocytokines, as we call it, be it leptin, adiponectin, a lot of inflammatory markers. So all of these inflammatory markers are indeed known to cause a lot of inflammation. Part of it is also related to insulin resistance. All this oxidative stress does come into play. But not only that, not only leptin and adiponectin, but also the other pathways, including the aldosterone pathway and the aldosterone angiotensin pathway. And again, there are a lot of studies, even in this paper, where we looked at all the hormonal changes in obesity. Aldosterone directly increases, is directly proportional to increase in fat. Several studies that have proven it, irrespective of salt intake. As the BMI increases, as the waist hip ratio increases, the aldosterone levels go up. And more recently, literature is also available that this increase in aldosterone is directly related to leptin. So as the leptin levels are higher in people who've got leptin resistance, something which is very common, and this leptin causes increased aldosterone, and this in turn activates the inflammatory pathway. Leptin disorders, leptin levels in our population is definitely high, including the prevalence of leptin receptor resistance. This is something that we've also seen in our population here. So yes, there is more leptin, there is adiponectin that comes down because of obesity. There are inflammatory markers. Again, as I said, adipocyte is a storehouse of different adipocytokines and inflammatory markers, and increased aldosterone and angiotensin, which not only activates the reticular activating system, but also the inflammation oxidative stress leading on to renal injury. The second pathway that is often a little less talked about, but yes, talking about insulin resistance. Obviously, when there is insulin resistance, there are large amount of insulin levels. Again, from the knowledge in physiology, we know insulin is an anabolic hormone. Insulin is known to grow up, whatever tissue is available, and that's how it also causes hypertension, because it builds up the muscle in the endothelium. And so, being an anabolic hormone, the growth factor release, again, there is said to be modulation of the podocytes, and this in turn leads on to renal injury and fibrosis. The third pathway, which is predominantly the presence of ectopic fat. Now, we all know that whenever we have calorie excess, ideally the amount of fat that is extra should go to the subcutaneous region, but our subcutaneous capacity to store fat is limited, and this extra fat starts to get in to all the other places where it should not, be it the heart, be it in the liver causing fatty liver, and even in the kidney and the omentum, that is the visceral fat. And this is the bad fat that is there, and just presence of this fat is known to cause renal compression, but also activation of the sympathetic nervous system, as I showed above, and the role of gut microbiota, and all of this leading on to increased tubular sodium absorption, volume overload, glomerular hyperfiltration, albuminuria, and how this pathway works probably you know better than me. So in summary, yes, there are different pathways how the adipocyte excess per se can lead on to renal injury, broadly classified as hemodynamic factors, the metabolic effects, and the presence of extra fat or lipid nephrotoxicity. So with so many mechanisms that were being described today, there is a specific disease entity which is referred to as ORG, or obesity-related glomerulopathy. This paper is fairly old, 2016, published in Nature Reviews Nephrology. Excuse me. And a lot of data has come up, but the key pointers that we need to remember about ORG is that this is something that is increasing. I've already shown you the prevalence of obesity, how it is increasing, not only globally, but even in India and even in Vellore. The ORG pathology is like an FSGS. They have subnephrotic proteinuria, adipokines, and ectopic lipid accumulation are the key pathogenic problems. And therapeutic intervention, and when this paper was written, was predominantly through RAS inhibition and weight loss. But as of today, and as I'll show you in these slides, the very effective anti-obesity medications are being studied in this entity, and whatever preliminary data is available, these medicines seem to do wonders, not only to obesity, but also the ORG that is related. And this takes me to the third aspect of the talk, why this is important and how this is really relevant to us as clinicians, looking at the impact of lifestyle, of medicines, or pediatric surgery, when we reduce the obesity or reduce the fat, how it changes the CKD status. So our overall understanding for obesity over the years has definitely changed. Now, the most recent guidelines don't talk about looking at BMI. This is the Canadian Obesity Network guidelines, which probably talk about moving away from just looking at BMI as a measure of obesity. Today, obesity is to be staged. It's not like BMI 40 is more unhealthy than BMI 38. This paradigm shift is happening today. Obesity staging systems are in place. This is one staging system that has been endorsed even by the Endocrine Society of India. What is the staging system? It stages obesity based on comorbidities. So I may have somebody who's got maybe obesity coming to my BMI of 39, coming to my OPD on a wheelchair because she has severe osteoarthritis of the knee, not able to walk. She would directly go to stage 3. I may have a 45 BMI person who's walking into my clinic and saying, "Doctor, I have no problem, I'm fine, no metabolic issues." She may directly come to stage 1. I may have somebody who's got diabetic kidney disease and just maybe stage 2 or stage 3. They would come to stage 2, but somebody on dialysis with a lower BMI might land up with stage 5. So even diabetic nephropathy is looked into when we talk of relation of staging of obesity, and the staging of obesity is irrespective of the BMI. Why this is important? Again, this is an interesting study. This is looking at NAINS database. If you look at BMI, you are not able to predict mortality. This is 15-year follow-up data. But just if you stage obesity using these kind of staging systems, where again, kidney disease is important, and now obesity-related glomerulopathy is also being included as one of the important components of the staging system, you see how well the mortality can be predicted. This is, again, as I said, endorsed by several Indian guidelines. When we looked at our own data from the obesity clinic at Vellore, we find that about 60% of our actually patients are in stage 2 and stage 3. And today the therapeutic guidelines, including the one that has been proposed by the Endocrine Society of India, are based on these staging systems. Like, you don't just look at BMI and suggest pediatric surgery and this patient for medical management. You look at the staging system and ORG being a component of it. So let's look at how well the renal impairment can be improved with lifestyle, drugs, and surgery. There's enough and more literature on how lifestyle is important, how dietary changes are important. But when you look at just if there is weight loss by lifestyle intervention, does that really help in terms of reducing the renal problems in terms of nephropathy? And this is data from 5,000 patients looking at median follow-up of 8 years. And we see that very clearly there's 31% reduction in the group which loses weight when we talk of delaying in progression of CKD. Not only this, just talking of physical activity, and this is data related to mortality in patients with end-stage disease. Again, looking at 11 studies together, and definitely higher physical activity. The weight loss that happens after that is associated with reduced mortality. So we're not just talking of improving the GFR and improving the creatinine levels, but we're talking about improving mortality as well. There's a lot of literature on nutrition related to obesity, and we often talk about protein intake, and this is something that is again to be emphasized, that irrespective of patients who have CKD, our Indian scenario of protein intake is very, very low. And for weight loss, I think even data from our center, we see that despite these patients eating a lot of calories, but they just still don't meet up the amount of protein that they should. So even in patients with CKD, we should be cautious before telling them to restrict protein. Talking about data on drugs, so far we did not have very effective anti-obesity agents in the market. When we wrote this guideline, say 4 years ago, semaglutide was just approved, injectable semaglutide, but was not really having that robust data that we have today. I think the landmark paper of injectable semaglutide was in 21, which was the step 1 trial. First time an anti-obesity medication showed 15% weight loss. These drugs are safe in CKD, even data showing for CKD stage 5, both semaglutide and more recently tirzepatide and cagrilintide. And a quick summary of the current drugs that we have for anti-obesity management. You see the quantum of weight loss by these drugs is actually reaching out to the scale of 22 and 25%, which is near to bariatric surgery. And the good thing is that these are renal safe. Talking about other modalities of weight loss, we at Vellore also do the intragastric balloon devices and bariatric surgery. And again, looking at the different literature as to how this helps in improving the creatinine levels or improving the proteinuria. Again, any kind of weight loss. This data is follow-up from 6 to 24 months, looking at a BMI drop of 4 to 15 kilograms per meter square. We see that overall, any kind of weight loss, no matter it is by lifestyle, by drugs, or by bariatric surgery, it does help to improve the renal functions. So friends, that's what I wanted to talk about, the 3 questions that we tried to answer. The prevalence of CKD through an obesity lens. We saw that obesity is increasing, and people who have higher grades of obesity have more prevalence of CKD, and this is just not only related to the comorbidities, it is independent of that. We saw how the fat is linked to the nephrotoxicity, the 3 pathways we spoke about, the hemodynamic pathway, the metabolic changes, and the insulin resistance that happen, and just by the presence of fat in the kidney, how that changes. We also talked about how treatment, be it lifestyle, be it medicines, or be it bariatric surgery, how it improves the renal function. So that's where I would like to stop. These are the key takeaways. Obesity and metabolic syndrome is increasing. ORG is something which is grossly under-recognized, but the prevalence is increasing. And lifestyle changes not only decrease the CKD severity, but also have an impact on mortality. So I think with this, I'll stop. I'd be happy to take any questions.
Thank you, sir, for this excellent talk. One question, in diabetic patients with diabetic kidney disease, in addition to the standard treatment which we have for preventing the progression of diabetic kidney disease, should we also consider management of obesity with keeping in mind the slowing down the CKD progression, particularly in mind?
So that's a very good question, and just maybe 2 weeks ago, the American Diabetes Association has come up with their recent guidelines for 2025. And this point has been included in the algorithm where right up they have said that patients with diabetes to be stratified on basis of obesity, and if they have obesity, the drugs that have to be used are the weight-friendly drugs and not the other drugs. So this has really come up in the algorithm. Yes, sir.
How, I mean, you have to continue it indefinitely, right?
Yes, sir.
So there's no question, I mean, because the moment you stop, you regain your weight.
Yes, sir. So the way we tell about it is, it's like any chronic disease. Today I have a patient with diabetes with an HbA1c of 9. I start anti-diabetic medicines. A1c comes down to 6. The day I stop, it goes back to 9. So they continue lifelong, treating obesity like a chronic disease. So it is a lifelong treatment.
And how expensive is it?
So it is right now expensive, but the good thing is that injectable semaglutide 1 milligram loses its patent in another 4 to 5 months. So this is 1 milligram, not the 2.4 mg, which causes the 15% weight loss. But the Indian companies have come up with a, if I may say, jugaad way. So they've come up with a vial of semaglutide. So ideally, it has to be dispensed as 1 mg, but that could be used as 2.4 mg. So injectable semaglutide and tirzepatide will be launched in India in the next 2 months. That's the original brand. But in 6 to 8 months, we may have something that's to the scale of 4,000 to 5,000 per month, which is affordable for a lot of patients.
Thank you very much, sir. So I request you to kindly accept a small token of appreciation from the department.